Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I am your host, Dr. Kishore Velody. And many of you have sent in questions over the years and even asked me in clinic a lot of questions about psychological conditions that can occur in Down syndrome. And one of the things that those of us who work in this field know is that there are very few experts in this field. And that's an unfortunate thing for so many of our children and adults with Down syndrome. But today we are going to be joined by Dr. Esbensen, who is one of those experts. I'm putting you on the spot here, Dr. Esbensen, but I'm so excited because whenever those of us who work in this field have a question and we want to get an answer to something along these lines, this is the person who we go to. So we are so excited to have you on the podcast. But before I get too far into it, would you mind telling our listeners who you are, what you do, and why you love working with this population?
Sure. So I guess I'm the expert, but I think that's because I'm the person who's actually doing it, and we need more people doing it so that we can have more experts. But I'm a clinical psychologist. I specialize in Down syndrome at the Thomas Center for Down syndrome at Cincinnati Children's Hospital Medical Center. I'm also a professor at our hospitals here. So I do research also in Down syndrome. Lots of research right now. So thank you to the NIH for really expressing an interest so that we can have more answers to some of these questions that Kishore is asking on these podcasts. In clinic, I see families to help them understand their kids or adults with Down syndrome and how to support their behaviors and their mental health. I also do individual treatment with adolescents and young adults if they're dealing with mental wellness concerns. And then I also do psychological testing to help inform the strengths and weaknesses of our kids so that we can best tailor educational supports for them. Why do I love what I'm doing? Oh my goodness, because it's not work, it's play. I've been playing with kids with Down syndrome since I was a kid. And so when I was in school and realized that all my volunteer work I could be paid to do this as a career, it was just like mind blowing. And I was like, this is fantastic. So to me, it's a community that I work with and part of, and I'm learning all the time. So I feel like I'm getting as much as I'm apparently giving. So to me, it's not work at all. It's just something that just comes naturally and I really enjoy.
And I love that. I feel like for those of us who work in this area, this field, I think so many people echo the same thing that you just said, which is, I can't believe I get to do this, and I think that's a really cool thing that you feel that same way. Well, what I was thinking, and during this podcast, I was thinking what we could do is just kind of go through some of the more common psychological issues that we may see in Down syndrome and just briefly outline how common are these things and really how do we approach them as parents, perhaps, or as caregivers. What would we do if we saw a child with Down syndrome or an adult, perhaps, with these conditions? So I'll start off with this one. Do we see depression in children and adults with Down syndrome? And the reason I ask this is that there is the misconception in the community that people with Down syndrome are always happy. So how could they possibly have depression? So let's start with that one.
So yes, they can have depression because otherwise this would be a very, very short podcast and we'd be
done. That's true.
So yes, they can. And no, not everybody with Down syndrome is happy and exuberant. And, even if they are happy and exuberant, they're not happy and exuberant all the time. And so that's different between having a depressive, major depressions, which is more like, a chronic condition versus having, a depressive day or having just like, an off day. So and we don't want to discount those off days. We still want to help improve somebody's mood. So thinking more of mental wellness versus is it a clinical diagnosis? But yes, they can have it.
And when you see depression and Down syndrome, what are the presenting symptoms? Like, what would make you suspicious for somebody having depression?
Well, so the good thing is there is in the general population, there's a diagnostic manual put out by the American Psychiatric Association that lists the symptoms that is required for making a clinical diagnosis. And so in that, there are 9 symptoms that we look for, 5 of which 2 of these one of these 2, and then in total 5 of these 9. So, again, you need a therapist to really make sure that we're getting a good clinical picture. But there is a companion manual that's been put out by a group called NAD, which is targeting supports for individuals who have intellectual disabilities and mental health concerns. And so they went through, and it's not specific to Down syndrome, it's more specific to intellectual disability. But they went through and said, okay, are there any adaptations we need to make to understanding what are the criteria needed for having depression or another mental health condition in the presence of intellectual disability. And so there are some caveats. So as a clinician, we know that rather than looking for 5 symptoms, we're looking for 4 of those 9 symptoms. And so we'd be looking for whether or not the individual has depressed mood or diminished interest. And that depressed mood can also be irritability. So that's what we sort of do when we're looking at symptoms amongst children, and we use that also amongst adults. We're looking for weight loss that's not intentional, concerns with insomnia or agitation, fatigue, feelings of worthlessness, difficulty concentrating, or recurrent thoughts of death. So those are the symptoms that we'd be looking for in the general population. And we're also looking for in adults or children with intellectual disability, and that includes Down syndrome. So again, we're looking for 4 of those 9 symptoms. And the symptoms have to be ones that are causing distress or functional impairment to the individual. So it's not just, and there's durations for how long these symptoms have to be present. So really not just saying, oh my God, this person has some feelings of worthlessness. Well, that's typical for most of our teens.
Yeah.
And so what's the combination of symptoms? How long is it going on? And how impairing is it to the individual?
So let's say that a general provider has a concern for somebody having depression and Down syndrome, and they send them to you, and you agree, you do your evaluation, and you agree that this person has depression. How do you manage it? Is there an approach that you take? Is it referring for medications, or is it therapies, or is it a combination? How do you approach this?
So first, I hope that provider, and because I'm agreeing with them, has already ruled out any other medical conditions that could have been contributing to some of the symptoms. So for example, with depression, if the thyroid's not well managed, we might be seeing some more fatigue, or we could be seeing irritability because of pain. So we want to make sure that we're getting all the other medical contributors screened out. But yes, medication is one option, but I'll defer to the psychiatry colleagues or my other MDs who are able to prescribe medications for options there. But there's various psychological treatments, and some of them will vary depending on the level of ability of the individual. So there could be, play therapies, there could be cognitive behavior therapies, there could be something that maybe is more trauma informed because of other stuff that's going on with the individual. It could, if we're looking at grief, and is it current grief? Is it prolonged grief? So there's lots of different factors that would go into making that decision. There are structured programs that are available, to provide a therapist with guidance on how to, modify what we know in the general population is effective to work with an individual with Down syndrome. So my go-to is so if you're coming to me as a therapist, that's great. I'm apparently the expert, so I know exactly what to do. But most of you aren't coming to me because you're not all in Cincinnati. And so if you're outside of Cincinnati, you're wanting to work with a therapist, ideally somebody who has experience with intellectual and developmental disabilities, because that's going to be a bigger region to catch from of therapists. If you can find one with expertise in Down syndrome, you're in one of the Down syndrome clinics, so you're fortunate. But if you are just finding a therapist who's available and willing, but just needs some more guidance, if I'm sure you've been listening to Kishore's podcast, so they know all about DISMIG. And so getting that therapist connected to DISMIG, because we're always happy to help a therapist just to sort of help them talk through different strategies to adapt their own skills so that they feel more comfortable working with this, adolescent child or adult with Down syndrome. But my go-to is I'm usually trying to help the individual, and I'm working with the family so that I'm kind of training the family to be the therapist so that they can support these skills at home, but is to work on developing a link between understanding that feelings and thoughts and behaviors are all related. And if we can change one of those, we can typically change the other one. Usually changing thoughts is more challenging for individuals if they have lower levels of ability, but usually thoughts and behaviors are a little bit easier. If I change what I'm doing, I can change how I'm feeling, come up with strategies so hopefully the individual can do them, but if not, the parents can prompt them or the caregiver can prompt them on how to change to a different activity so that we change what we're feeling. If we can change a thought, I did a group with a bunch of adults, and they were fantastic about coming up with different thoughts for other people. And so sometimes having them think about other people rather than thinking about their own thoughts is easier. But again, those are coming up with spontaneous and novel and generating of ideas, which is not always a strength. So, we try to work around that and coming up with examples to be like, how does this one sound to you? How does this one sound to you? And then the person will pick what they think is a good idea. And then lots of what I'm doing is recognizing that the depressive episode, could be triggered by an event that was years ago, but the individual sees a picture that triggers a memory, they get into a depressive funk. So it's not maybe a major depressive episode, but there's something triggering. So in the moment, they're more sad or upset. A family member or a family pet passed away, they see a picture of them 10 years later, and they're grieving as if they just lost that person or that pet. And so how do we change their thinking in that moment to something that's a more positive, highly salient memory? Because that salience, like the loss of that person or pet was very salient. So how do we change it into another more salient, positive memory, so that they don't keep spiraling into that, sort of negative, that sort of one-track mind, thinking about that negative, like loss. How do we shift it to something more positive? Mm-hmm. But if you guys haven't read the book by Dennis McGuire and Brian Chicoine, The Mental Wellness in Adults with Down Syndrome, and I know it says for adults, regardless of age, read that book. It really is a great book for understanding mental wellness across the board, and a strategy that we can do that are preventative as well. And so preventatively, that's a great thing. I know you might have want to jump in, but I just keep talking.
I know this is great.
Preventative strategies. So it's, you're talking about somebody like you have symptoms we're concerned for, they've gone into their MD, they've gotten to a therapist, we're doing treatment. I'm like, yeah, but before that, what can all these listeners
That's
do
great.
before they get to having, a kid that they're concerned for? Make sure your child, adult has words or pictures to label their emotions, and not just happy, sad, scared. Like try to get, more pictures. We have emojis. Use their, phones or tablets. Use as many, natural forms of communication to sort of link their thoughts so they, in those other moments, they have the words in their arsenal to describe what they're thinking and feeling. And also model your own coping strategies, but like much more obviously. So rather than being like, I had a bad day at work, all these things are happening, I'm really stressed, I'm just going to go and read a book and off by myself and just take some quiet time. Talk about what you're doing so that it really is obvious. So sort of talking out loud, being like, I had a really hard day and I'm going to just go read a book to relax and calm myself down, so that you're really, sharing what those coping strategies are, so the end of your family member can sort of see and learn from that. It really needs to be more obvious, more didactic in a sense, but you don't have to say, hey, I'm feeling stressed, so I'm going to do this, because then they're going to be like, why are you talking to me? But that you're sort of being much more obvious about it for
like a natural modeling kind of.
Just sort of talking out loud. So we know our folks with Down syndrome like to engage in self-talk and talk out loud. They sort of don't curb that impulse to sort of have those inner monologues. Mm-hmm. And we do as neurotypical parents, we do a better job thinking inside our head, and we need to do a better job talking out loud so that the individual with Down syndrome can really understand what we're thinking.
That's great. And I love the way that, because so much of the uniqueness, I think, of working with the population we're talking about, those with intellectual disabilities or specifically with Down syndrome, a lot of expressive communication might, by enhancing that ability for them through whatever the therapy models are, the play therapies, things that don't involve a lot of, hey, sit down and tell me about your thoughts and feelings, may not work quite as well. And so I love the way that you've kind of described the approach being less, if needed, less verbal speech directed and more emotional, getting that information from a different technique. I think that's great.
And also recognizing that we don't have to prescriptively teach the person a specific word, like you need to learn the word depressed. Mm-hmm. You need to learn. The other individual, like your individual with Down syndrome, might come up with a completely different word. It doesn't work for depression, but I had a young woman who had anxiety, And she described it feeling like a ghost because she just sort of felt hollow and empty inside. And so she called it being a ghost. And I was like, oh, that's a fantastic word. So, if that's the word that, within the family, it doesn't quite help if it's a new person who doesn't know them, but you might use the emoji for the picture of ghost, or, something about, okay, how ghosty are you feeling?
Yeah.
So sort of look at how, how anxious they might be in that situation. So rather than a fear thermometer that we might use to label feelings of anxiety, you could, like for her, we had to use the size of the ghost.
Okay.
Describe how, nervous and like sort of empty she was feeling.
Which is kind of it's a time for us to really transition, because one of the other questions we get a lot about is anxiety. And do we see anxiety in children and adults with Down syndrome? Again, that false narrative of everybody with Down syndrome is always happy and carefree and things like that. But what would your answer be in terms of, do we see it? And what would your approach be?
I'm convinced that when we get more genotyping studies, there's going to be something related to anxieties that is on chromosome 21. Yeah. I don't care if it's a protein that encodes for something else or something, there's going to be something. So I put it on Kishore's podcast. So when it comes out, you can quote that, I said it first. Right. But yes, but with anxieties, and I get to say that because there's a lot of different anxieties. So there could be selective mutism, which would be the child, only talking around certain people and then refusing to talk around teachers. So they'll only talk at home with family and they'll refuse to talk with other people. Could be separation anxiety. So just that fear of I don't want to be away from the home. I don't want to be away from my family. Social anxiety. So fear of being in, bigger groups or having to go up on stage or perform in front of the class. Phobias, so just fear of certain items, they're scared of dogs, they're scared of, there's just so many different phobias that I deal with in clinic. But panic attacks, agoraphobia, and that we all had that after the pandemic, but sort of fear of open places and being around lots of people, and then general anxiety. So that's more like the constant worries. So there's lots of different anxieties. That companion book to the diagnostic criteria doesn't really make a lot of adaptations. So we really are using the same criteria that for anxieties that we would use in the general population that we would use for individuals who have intellectual and developmental disabilities. But so for people, and I'll just go through one of them, but for general anxiety, we'd be looking at this excessive worry or fear, and that the individual has difficulty controlling their worry. They would also have physical symptoms, so like stress headaches or butterflies in the stomach, and then those symptoms cause that person distress. They don't cause the family distress, they cause the person themselves distress. So yeah, they can still be present.
And then when you make that diagnosis, is there an approach style that you would use in order to help that person, I don't want to say overcome, but at least figure a way to work through or work with their anxieties? What would your approach be there?
Again, rule out the medical contributors that could be there. Yeah. Talk to the physician. Usually anxiety or medications are going to be, something that's going to be very, very helpful. Sometimes I'm in clinic and I'm teaching them all the behavioral strategies, but until they get that anxiety medication to bring those anxiety symptoms down a little bit, they have too much anxiety that they can't actually learn and employ the behavioral strategies. And so once the anxiety comes down with medication, then the person can start using the behavioral strategies that we teach, and then eventually we can fade off medication. So you really want to have an interdisciplinary team working together. And it doesn't have to be like, oh, it's part of a clinic. It could just be that the physician and the psychologist know, or that the therapist know what's going on within the other one's care. But there could be, strategies that are used in terms of learning coping strategies of deep breathing techniques to use, and muscle relaxation. Because if you think, if we all get worried, we all get, tense and stressed. And in that moment of excessive worry or excessive phobia, someone coming up to us and saying, hey, don't worry.
Yeah.
So you're and so they're like, hey, take a deep breath. And you're just like, I'm too stressed. I'm breathing deeply.
Yeah.
It's not going to necessarily be helpful. So having the skills taught beforehand so that we can then just be modeling. So not using our words, we can, and we're on audio, not video. So it's kind of hard, but you'd be, taking a deep breath in taking a deep breath out to sort of model for the individual rather than saying, hey, take a deep breath, your coping strategies.
Yeah.
Because in the moment, don't talk to me. I'm not listening to anything you're saying. I can't take words in. There are, again, structured programs that are available for managing fears, for managing anxiety that are appropriate for children, appropriate for being modified for adults who have intellectual disability. Most of the strategies focus on teaching those coping strategies and then some form of successive or sort of gradual exposure to that feared stimuli. So whether it's pictures and then videos of what you're scared about or worried about, and then being in that situation more closely, and then more getting closer and closer to that scared item or event or thought. But at each moment of being gradually exposed to that item, you're working on your coping strategies and decreasing your fear so that you're able to leave that situation and feel like I was able to manage my fear. Because if you put a person in the situation and then they get and they're at the height of their fear and then they leave, we just reinforce them that you should just be scared of that item. And so it's it really is, behavioral principles 101. You don't leave a situation until you've calmed down, but we're not going to get you, clinically in front of something that's scary until we know that you can cope with that one. So it's very gradual exposure with lots of coping strategies. So that's the sort of desensitization, but there, some people use flooding. So there's other strategies that people can use, but really do those with a therapist. There's lots of different workbooks that can be adapted to sort of help the individual. But sometimes it's your excessive worries is, could be just it's sticky thinking, you're just thinking about something over and over again. How do we break that ruminative thought? So it's more, how do we manage what you're thinking to shift your thinking to something else? But then is it, sticky thinking and worrying, or is it, I forgot when we're going. You told me I forgot when we're going. You told me I forgot when we're going. And so is it repetitive asking because I forget, or is it repetitive asking because I'm worried? So really trying to figure out what's the root cause of it.
Wow, that's really helpful. So I feel like we've talked about depression, we've talked about anxieties, of course, just a general kind of overview of those things. But one other area that I wanted to make sure we touched on in this podcast, because quite honestly, I have some questions about this too, in that obsessive compulsive disorder. It's something that comes up quite a bit in terms of questions, particularly with the teens that I see, but I'm sure with adults that my colleagues see as well. And the challenge, particularly in people with Down syndrome, is that we know that they have so many people with Down syndrome have this desire for sameness. It seems like I always do it the same way every day, so I'm going to keep doing it that same way. And that desire for sameness in an ever-changing world is kind of how I've heard other people discuss it. It just gives them a sense of calmness in the midst of all the changes going on. So some of that can look like OCD, perhaps obsessive compulsive disorder. Some of that, I have to wash my hands like this way, or I have to brush my teeth at this time, or this show always comes on at this time and I must watch it. Otherwise, something's going to change in my world. And so what is your approach? Do we see actual OCD in people with Down syndrome? And if so, how do you diagnose? How do you think about it?
So yes, we do, of course. And so we see a lot of OCD behaviors, and we also see some OCD.
Okay.
When we see OCD, it has to be functionally impairing to the individual, that if they don't stop their compulsive behavior, that they're going to feel anxiety and that sort of agitation, irritation, learning a routine and then being interrupted and being like, oh, where am I? I only know how to start this routine if I go from back to the beginning. That's more just to do with how they've learned the routine and not being able to jump into it mid task. So that would not be OCD. It's more if it's like that, I have to fulfill this whole bodily routine of movements before I can go through a door, or I have to wash my hands for this whole song before, which actually was adaptive during the pandemic. But so again, it's figuring out, when is it adaptive? When is it something that helps the individual with understanding and remembering their routine and getting through their day? Nobody likes, changes to their routine. And so, if it's they're imposing it versus somebody else imposing it, When we've imposed a change, we're increasing their stress. And that's just, so how are they functionally coping in that situation? How did we introduce that change? So there's strategies we can do to introduce the change in a more appropriate manner to help the individual then make those changes. But if it's functionally impairing for the individual, then that's when we would look at treatments where we would be teaching them again those coping strategies and how do they shorten their routine. We're not going to go from a half-hour routine from getting from the car into the house by crossing that door threshold. We're going to decrease it by like 5 minutes and then another 5 minutes and decrease the length of the routine. So we're going to make those small incremental changes to their excessive routine, because that's when it has a functional impact. But recognizing that our individuals typically have different brain development in the frontal lobe, which is where we're able to come up with different plans and transition quickly. And so our brains of individuals with Down syndrome are working at their maximum capacity to just go through their day. And then we're saying, hey, you need to shift to something else. And they're just like, my brain's overwhelmed. So recognizing that the individual is trying to be as flexible as possible, but it's really hard to shift to another plan without us giving them a lot more supports beforehand.
So just so I'm clear, so from an OCD actual diagnosis perspective, it really it's about how much does this actually functionally impair them for the day? Like they will not leave the house until they've washed their hands 15 times or something. Would that be kind of what you were talking about, or
so if the person has to complete their routine and they're not getting out the door for school in time, that's more of a functional impact on the family.
Got it.
It's whether or not the individual is like, if I don't get this done, I'm going to feel lots of stress and I'm going to feel like there's something that's worrying that I didn't get this germ off of my hand. And
got it.
So in either case, we can still reduce their routine using behavioral strategies. So like whether it's if it's a functional impact on the individual's thinking, that's OCD.
Got it.
The other one is more like obsessive compulsive behaviors, which has the functional impact on the family. Both are problems. Both can be treated.
Got it.
But the label might be a little bit different.
Got it. Wow, this has been so helpful. Honestly, I think that each of these, I bet you could be a half day or a full day seminar that you might be able to run a family through. And so the fact that we're able to cover this so quickly as an overview is great. Are there any resources or materials? You had mentioned the Mental Health in Adults with Down Syndrome book. Are there any other resources that come to mind that we can share with our listeners?
I would, if they're interested in really deep diving into the diagnostic criteria, I would look up that diagnostic manual for intellectual disabilities that's published through nad.org, I believe. I would always, and also nad.org has likely lots more supports in terms of mental health in intellectual disabilities in general. So not specific to Down syndrome, but in terms of trying to find resources that, therapists might be able to access. I'm always a fan of going to your local USED or LEND programs. So those are University Centers of Excellence in Developmental Disabilities, or these leadership programs in neurodevelopmental disorders. I forget what they all stand for, but those are programs that are in every state that will have resources targeted more towards intellectual and developmental disabilities. And so using those resources to get connected to local therapists. And then the Woodbine House books, which we know are getting the publishing company is getting retired. So we don't know where those books will have their new homes. But we know they'll have new homes. But that mental wellness book and the positive behavior strategies, so those are a lot of the strategies that we would still use to manage some of the mental health symptoms, are still good things to use preventatively. Those are the things off the top of my head.
That's perfect. Thank you. And I will definitely include links to those resources in our show notes for our listeners. Well, Dr. Esbensen, this was fantastic. This is exactly what I think our families were looking for when they were requesting a podcast as an overview of these topics. to our listeners, I hope you found this as educational as I did. And to those who sent questions regarding any of these topics, I hope you found this helpful as well. As always, if you would like us to cover any topic whatsoever, just please send us an email to downsyndromecenter@chp.edu. If you would like to join with what we are doing here at the center, including this podcast, please do go to givetochildrens.org/Down Syndrome Center, and we'd love to have you join us. But until next time, bye-bye.